And we do want to thank Cody Mullen for being with us today. He is our Network Development Coordinator here at the Indiana Rural Health Association, and he's put together an excellent presentation on MACRA. Cody, I'll go ahead and turn it over to you.
Thank you, Allie, and thank you, everyone. It's so wonderful to see so many joining us this Tuesday afternoon during your lunch break. Thank you for the opportunity to let me share with you MACRA 101 from the Indiana Rural Health Association's perspective. Before I get started, I just want to preface this speech and presentation that the final rule on MACRA has not been released yet. So everything that's been based in this presentation is on the proposed rule, and I'll get into the process of that in a little bit. But this is subject to change once that final rule is released from CMS. So as we go through today, if you have any issues or questions, as Allie mentioned, please chat those to her. I have just closed my chat window. I'll reopen it at the end of the presentation, but that's too distracting for me to be reading that. So if you have any issues or any concerns, please go directly to Allie, who's listed as the host. So where are we going today? We have three main areas I would like to cover today. First off, a quick overview of healthcare, health, and the Affordable Care Act. Some of the changes that have been occurring throughout that, which will probably be review for most people on the line, but just want to kind of do a level setting, base setting of the history. Then do a deep dive into MACRA at the 101 level. What is it? What's it look like? The timetables, what measurements are we going to be looking at? And then the two different pieces of MACRA. We have MIPS and APM, and we'll go into what that is. And lastly, kind of want to go through some of the Indiana Rural Health Association's MACRA education that we have planned for the fall of 2016. So as we're going through, I first want to start off with the Affordable Care Act. The CMS Innovation Center was formed through that under Section 3021. And their main focuses were on three different areas, focusing on Medicare, Medicaid, and CHIP, looking at new payment and service delivery models, evaluating results and advancing best practices, and engaging a broader range of stakeholders to develop additional models for testing. This is formed. A lot of different things have come out of CMMI, as its acronym has been called, including the ACO model, Accountable Care Organization model, CPC Plus, the Accountable Health Communities, and various other models that have been coming out since the Affordable Care Act was passed. It sits within CMS, and the director of this is the Chief Medical Officer of CMMI, or of CMS, Patrick Conaway. Fast forward a little bit, moving on into 2014-2015 timetable, Secretary Burwell came out saying that she challenged the healthcare system, primarily Medicare, Medicaid, and CHIP, to transition as much as possible away from service payment models into payment models that are linked either to quality or what we call an APM or alternative payment model. And the goal for that was in 2016, 30% of the system would be an advanced payment model. 85% of fee-for-service payments would be linked to quality, including an APM, of the 100%. That we're now in 2016, so that goal is being worked towards, and will be interesting to see at the end of this year as CMS reports out their payment breakout, how they've done towards that. But then in 2018, the goal is to increase that alternative payment model from 30% to 50%, so to capture half of all CMS payments into that alternative payment model, and then 90% overall of all payments made would be linked to quality through fee-for-service, and only 10% would lie in our traditional fee-for-service models as we are today. I do apologize for those of you who are looking at this going, why is he just bringing the slides to me? I am trying to verbalize the depictions for those who are just on the phone. So I do apologize if I'm just bringing the slides to those who are seeing them. In addition, around the same time frame, a little bit before the Affordable Care Act, the work of David Kindig and University of Wisconsin's Population Health Department came up with this infographic and this study looking at what affects our health outcomes. So if we look at mortality, morbidity, length of life, and quality of life, 50-50%, what programs and policies will affect those outcomes, and what health factors do we have to intervene on to have the outcomes that are desired of longer life and lower morbidity. And surprisingly to a lot of people, or at least to me, only about 20% of what happens in the healthcare sector or clinical care sector, only about 20% of overall health outcomes are factored by that sector. The other 80% are made up of things that the healthcare system does not have direct control over. Those include our physical environment of 10%, our social and economic factors of 40%, so education, employment, income, family, community safety. And then also 30% of health behaviors, tobacco use, diet and exercise, alcohol use, unsafe sex as examples. So of the overall 100% goal that we as a healthcare industry are charged with improving on, we only have direct control or direct influence over 20% of that access and quality of care. And arguably, those are very hard to control unto themselves. But now we're being tasked through these goals set forth by CMS, CMMI, and the Affordable Care Act to have direct impact over all 100% of this, so behavior, economic factors, and physical health. And that is where, as we go down, we do a whole history lesson today, and I really don't want to get into that, but where we get into MACRA. And what exactly is MACRA? I'm curious, if you could put in the chat window, I'll look at the end. I'm just curious to see how many of you are familiar with MACRA, on a scale of 1 to 10, where you let rest on your MACRA knowledge. But MACRA was passed back in 2015, and MACRA stands for the Medicare Access and CHIP Reauthorization Act. And as I talk to colleagues and to students where I teach, and I say only in healthcare will we use an acronym for an acronym. So CHIP is the Children's Health Insurance Plan. So how do we refine our Medicare and our CHIP? That's all handled at the federal level. And before we can really dive into what is MACRA as our application, first thing I want to look at, how was the law passed? So it was passed, like I said, back in 2015. So it was a year and a quarter, year and a half old law. It was Health Rule number 2. It was first introduced to the House on March 24th of 2015, and it was heard by 6 committees in the House. And quickly, within 2 days of it being introduced into the House, it passed the House. I want to highlight here, not to get into election season and all that, but it was passed with bipartisan support. 392 of our 435 congressmen did support MACRA and voted in favor. 8 of the 9 elected officials from Indiana did support MACRA. Then within about 2.5 weeks, that went on to the Senate, where again it got very strong bipartisan support. 92 of the 100 senators did pass MACRA, and sent it on to the president. And President Obama did receive and sign MACRA on the same day. So less than a month did we go from introduction to the House to having law in place. At the Senate level, both Senator Coates and Senator Donnelly did vote in favor of MACRA. So again, very bipartisan supported legislation that went through. From there, MACRA went on to become a proposed rule that CMS really had major authority to do. And it took a full year. Monday on May 9th of this year was a MACRA proposed rule was released for review. They've done a lot of work on the back end, doing focus groups and panels, but that initial, here's what we're thinking as a whole of MACRA came out. And this is 426 pages of the Federal Register. And I have a little screenshot here so you can see, it's a three-column page, very tiny print, detailed. I got the PDF of it that was a single double-spaced single column, and it was about 950 pages. It was open for comment up until June 27th. And they're now reviewing all of that comment, and we anticipate, keyword there is anticipate, that sometime next month we will see that final rule. We have seen a rule or comments come from Andy Slavitt, the acting director of CMS, that MACRA implementation may be delayed past the January 1st, and we'll get into the timetable here in a few minutes. But right now, if everything goes as initially planned and discussed, our understanding is we'll see final rule in September of 2016. So what were the goals of MACRA? Well, really, MACRA had 3 overarching goals. First is ending the sustainable growth rate SGR formula for determining Medicare payments for healthcare provider services. It was to make a new framework for rewarding healthcare providers for giving better care, not just more care, getting at that value-based care that Secretary Burwell was asking for, combining our existing quality reporting system into one new complete system. And we'll get into that as we get into MIPS, what is going away and what is being combined. So I kind of want to look at initially, and I'll have the slide again at the very end, so if you are on the road right now and are going to log in at the end, you will get to see the slide again at the end. But if we look at our timetable, it's going to start next year. January of 2017 is when the initial data collection is going to begin for MIPS and when people can start getting or can continue being into an APM, an advanced payment model. If you're in an advanced payment model, which we'll get into at the very end of today's presentation of exactly what that looks like, but if you're in an advanced payment model, you are immune, or you don't have to participate in the MIPS program. If you're not in an APM, you're automatically in the MIPS program. The initial data collection, like I said, starts January 1st. That initial fee or penalty, a bonus or penalty, will then be assessed in 2019 based on 2017 data. Affordable or MACRA is a budget-neutral legislation, which means for everyone who gets a bonus through MIPS, a equal party will get a penalty. We anticipate roughly $880 million of bonuses. Inversely, we anticipate $880 million of penalties. Starting at 4% of overall Medicare reimbursement is based on our understanding, and growing up to 9% of Medicare reimbursement by year 2022 and continuing indefinitely based on current legislation. If you're in an advanced payment model, though, you do qualify for 5% incentive payment, and you're excluded from MIPS. And again, that incentive payment is supposed to be starting in 2019, and it'll run through the end of 2024. And then in 2025, we would anticipate there'll be new legislation, and best practices from those APMs will go in to create legislation. So before we get into MIPS and MACRA, first off, overall, or MIPS versus APMs, MACRA as an overall, create a measurement development plan. This is started late in 2015, before the proposed rule came out, basically saying, okay, we're going to have all of these penalties, we're going to have all these bonuses, we have these new programs. What is best practice? What is evidence-based models that we can utilize to measure, to assess very unbiased ways across the healthcare system? So initially, a plan for that was drafted and posted on CMS's website right around Christmas time of last year, December 18th. Open comment was allowed through March 1st, so roughly 2.5 months. And CMS reported that they have received measurements or comments, excuse me, from 60 individuals and 150 institutions. That final quality measurement plan, which we'll get into here in a second, was posted May 1st, again before the proposed rule came out, where this is integrated into that, and applies both to MIPS and to APMs. So I do apologize for those of you on the phone that this chart that I'm showing right now is very busy. If you'd like to email me, my email will be at the end, and I'll read it off to the end that you can write down. I am more than happy to share the slides and the charts that we're using today. But basically, they said that the final MDM came out in May of 2016. In June of 2016, the call for final measures ended. We anticipate that in November of 2016, our final measures for the 2017 calendar year will come out. And those will be out no later than November 1st. And then we have a cyclical factor. So in January 2017, our initial review will start of MIPS for those facilities who are participating in MIPS and who are not in APM. But then April projected, quote unquote, is when we will say, okay, what do we want to change? What literature, what scientific knowledge has changed over the past year since we've come out with our last one that we want to update for 2017. They anticipate that call for measures will end in June, and then in November of 2017, we'll come out with our 2018 measurements for our second year of MIPS. And that cycle we anticipate will be repeating every year on that time frame. Again, this is predicted, but this is what is the current plan that was released in May. And this was final that came out in May of this year. So this is final. We're not weighing up proposed rules on this as we believe. And they identified for 2017 that we're going to focus on 6 key domains for our measurements. And those are clinical care, safety, care coordination, and then our next slide we'll get into patient and caregiver experience, population health and prevention, and the affordable care. So in clinical care, what did they identify? And these are direct quotes from their documents to ensure that I'm giving you non-biased or non-interpreted, but this is what they stated, was to measure incorporating patient preferences and shared decision-making, cross-cutting measures that may apply to more than one specialty, focused measurements for specialties that have clear gaps, and outcome measurements is really where they're looking at clinical care. For safety, they're looking at diagnostic accuracy and measurement safety related to important drug classes. And we can get into further in Q&A what they identified those. But with the opioid epidemic, that was definitely a very high list there. In care coordination, they're looking at assessing team-based care, so that timely exchange of clinical information, and then effective use of new technologies such as telehealth. For our patient and caregiver experience, what we're looking at here is our patient-reported outcome measurements, or PROMs. If we think back to PCORI that was funded under the Affordable Care Act, trying to tie in the literature, the research that PCORI is doing, patient-centered outcome research, excuse me, into MACRA, into MIPS, and into measurements, as well as additional topics that are important to patients and family caregivers. For example, knowledge, skills, and confidential self-management. We're also seeing a lot of population health prevention as we go to that value-based care, keeping the population healthy and not treating them as they become ill. So developing or adopting outcome measures at a population level, such as a community or other identified population, to assess the effectiveness of health promotion, preventive services delivered by professionals. They're also looking at the IOM vitals science topics. So Institute of Medicine came out with a report back in, I believe it's 2014, maybe early 2015. For example, those for life expectancy, overall well-being, and addictive behavior, as well as detection of preventative of chronic diseases, for example, chronic kidney disease. And then also looking at affordable care, so looking at overuse measurements, overuse of clinical trials, and or procedures. So now what I want to do is dive into the two pieces of MACRA. Like we've been saying, there's MIPS, which stands for the Merit-Based Incentive Payment System, and then there's Advanced Payment Models, or APM. So now we're looking at just MIPS. Again, I want to highlight that all facilities in 2017 will fall under MIPS unless you identify as an advanced practice model. So this again is directly from CMS's website, but this is what they identified. So the MIPS is a new program that combines parts of PQRS, or the Physician Quality Reporting System, the Value Modifier, or VM, as well as the Medical Electronic Health Record, EHR Incentive Program, into one single program in which eligible physicians or professionals will be measured based on quality, meaningful use of certified EHR technology, clinical practice improvement, and resource use. So let's start with quality measure. Quality measures are going to make up 50% of the total score in the first year of MIPS, so that 2017 year. And what are we looking at, or what is the proposed rule, at least, identified that they're going to be looking at for this? Is patient outcomes, appropriate use of care, the patient safety of care, efficiency, the overall patient experience, and care coordination. A lot of things that I know a lot of our member facilities who are in an ACO model are already striving towards and working very heavily towards, as well as other facilities are working with that. Again, this makes up 50% of the overall total MIPS score that will be developed per provider, per qualifying professional. The next 25% of this will come from advancing care information. This is formerly known as our EHR meaningful use. So are we protecting patient health information? Are we using e-prescribing or e-pharmacy? Are we using patient electronic access, patient portals? Is there coordination of care through that patient engagement? Are we participating in utilizing a health information exchange? And are we also participating with public health and clinical data registries? I noticed during the beginning, we have one of our health information exchanges, at least one, who identified who's on the call today. So again, this makes up an additional 25% on top of that clinical care. The next 15% of our total score has over 90 activities that are going to be focused on. This is our clinical practice improvement. I want to give a shout out. I don't know if they're on our call today, but the Great Lakes Practice Transformation Network, which is based here in Indianapolis, that covers 5 states. They're working very heavily with providers on these 90 areas, as well as the other areas identified within MACRA. So strongly encourage you to reach out. And if you don't have connections with them, please reach out to me, and I'll be more than happy to make connections to that group for you if you're not already connected. But of those 90 activities, some of the ones that we would like to highlight are expanded patient access, population management, beneficiary engagement, again, coordination of care. Notice that that's being themed throughout all of these. Patient safety and practice assessment, emergency response and preparedness, and integrated behavior and mental health. Again, this makes up 15% of your overall total score as you're working towards improvement. Lastly but not least is our cost or resource use. This is going to be the remaining 10% of the total score. There is no additional reporting based on the proposed rule, I will highlight, on this, and it will be calculated based on claims data that is gathered from CMS as claims are being released and promoted. So Eds MIPS, again, everyone qualifies for MIPS. That's budget neutral. So if you're a high achiever on MIPS, you get a bonus at the end of the year, starting in 2019 based on 2017 data. So they have 2018 to spend the year analyzing the data and determining all of that. If not, you can opt in to participating in an advanced payment model, or APM. This payment model includes 3 unique features. First off, the physician or clinician must bear a financial risk through that payment model. That base payment is based on the quality measures comparable to those in MIPS, and you must use a qualifying EHR. What are some of the different models that are eligible for a advanced payment model? Well, one is end-stage renal disease care. Another is the Comprehensive Primary Care Plus program, CPC Plus. Currently, Indiana is not participating in that program. CMS came out first part of August, I guess first part of this month, with the regions that they're going to pilot that program with. Indiana was not one that was selected. We hope in the future that we'll be eligible for those. We are also for Medicare Shared Savings, Track 2, Track 3, and Next Gen ACOs. So these are ACO shared saving models where there's that risk barrier or risk assessment. Currently, I've been told by our colleagues at the Purdue Healthcare Advisors that there's only one ACO down at Evansville. I believe it's Deaconess's. That is the only ACO in the state of Indiana that qualifies as a financial risk ACO. All the other ACOs currently do not have that financial risk model on that. Also, bundled payment models qualify. So as the new knee and hip and ortho bundled payments come out, as we generate new bundled, or not as we, as CMS generates new bundled payment programs, those also qualify underneath the advanced payment model. And then also the oncology care model. So I want to bring this slide back up, that MACRA timeline, now that we went over the 101s of the 2 programs. So MIPS, again, is going over quality, it's going over resource use, it's going over clinical practice, it's going over meaningful use, it's combining in that PQRS, that value modifier, that EHR initiatives or incentives into this one program. Again, data collection starts 2017, and penalties and bonuses, pluses and minuses, payment adjustments will start in 2019, starting with 4%. Advanced payment models, again, are starting now in 2016, 2017, and that 5% incentive payment for participating in those will start in 2019, as well as excluding you from MIPS in 2019. Again, subject to change. We'll see what happens if the proposed rule comes out. We may delay this. But we anticipate IRHA's belief. A lot of my colleagues and I have done a lot of research and discussions over this. We believe that MACRA will not go away. If anything, it will be delayed, but it will be coming out regardless. So just kind of want to go over some opportunities. Again, this is a 101. I want to leave plenty of time at the end, since we have such a great attendance today, for a Q&A and discussion amongst, as I don't feel anyone is an expert in MACRA yet, as it's so broad. So I want to leave plenty of time for question and answer at the end and discussion. But some opportunities. So we're collaborating. There's a rural collaborative with HFMA and their Fall Institute, which will occur October 6th and 7th. It's going to be held at Bloomington at the Marriott Courtyard. Registration is open on the HFMA website. It's a day and a half. We have a lot of different speakers. I will be doing a deep dive into population health aspects of MACRA. We have other speakers doing a deep dive into MIPS, a deep dive into APM, deep dive into MACRA, what does it mean, as well as other wonderful speakers coming in. So strongly encourage. It's a 2-day face-to-face opportunity. IRHA members, we are in collaboration on that. You can access that from our events page on our website. In addition, for our intern members, our hospital network, we have our trustee education event. This is a free event for our hospitals on November 3rd. We have 2 different sessions that day, a lunchtime session and a dinner time session, of which MACRA will be discussed at each session. And then we're also very interested in doing special events for your facility. So if there's anything we can do to be of benefit, either through a virtual platform or coming on site, we're more than happy to do that as well. I also want to highlight, as these transitions are happening, there are a bunch of programs out there that CMS has been releasing or will release to help drive towards the growth of MACRA, or the basing and getting ready for a MACRA. It does include the accountable care organizations, the shared saving programs that are out there. The National Rural Accountable Care Organization has one. That includes offering chronic care management, or CCM, through your practice. If you read the chronic care coordination or care coordination pieces of MACRA, and you read the CCM regulations that came out in 2014, 2015 timeframe, they're very, 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 very similar. So that's an opportunity now to start offering that. That would drive additional revenue to your facility, as well as working with the Transformation Network, the Great Lakes Transformation Network, and preparing your facility towards that as well. But again, today was really a 101. We wanted to go over an overview of what MACRA was, the 2 different areas of where MACRA was, and to let you know, as we go throughout this next 2 or 3 months, that we have a lot of opportunities here at IRHA for continuing education, as well as to come in and do a deep dive that's very specific to your facility that would be the most beneficial. So with that, I would like to open us up to questions and answers. Allie's going to serve as our moderator. But before I do that, for those of you who are on the phone, I'd like to tell you my email. I'm more than happy to answer questions or to share information or to discuss more with you. My email is cmullen@indianarha.org. Again, that's cmullen, cmullen@indianarha.org. You can also find my information on the Indiana Rural Health website. Also, for those of you who are in the southern half of the state, we'll be going to the MACRA event in Louisville that starts tomorrow through Thursday. I will be there as well, so please stop by and say hi. I look forward to meeting you face to face. So with that, Allie, I'd like to turn it over to you for Q&A, as well as I will look to see what might have come through my chat window that was sent directly to me.
Well, I think you'll probably see, Cody, we do have one question that's come in already in the chat. Do you actually have to enroll in MIPS, or will that be automatic?
It is our understanding right now that you will automatically be enrolled in MIPS if you have not opted out and enrolled into advanced payment model. To be honest, we've not done super deep dive into that as we're waiting until the final rule to come out on that, because we have a feeling that it's going to change or be one of the areas that's going to have a drastic change, if any area has a drastic change. But it is an automatic enrollment in MIPS unless you have that opt-out for that APM.
We've got another question in the chat. Looks like someone would be interested to hear how technology and EHRs in particular are prepared to handle the collection of the information MACRA measurements will be based on.
Yeah, that's a great question, because as technology changes, a MACRA in a way is replacing the role of meaningful use. So it's going really, really well. We're seeing as these new programs come out, there are EHR lacks there. For example, for chronic care management, which is a program that I work directly with our association, there's that 20-minute avenue of it. You have to provide 20 minutes of care coordination. A lot of EHRs are not really good at saying how much time to the second have you spent on a patient. So we're seeing a lot of companies are offering solutions for that. We're also seeing a lot of the bigger players who are transitioning to include that, including more of a population health module for that disease management, for that prediction modeling as well. We have some technology companies on the phone today as well that are doing that. I anticipate, this is Cody speaking, not IRHA. I anticipate a lot of things are going to roll out at HIMSS when we have the HIMSS conference in February 2017. We'll kind of see what that final rule is, see the timetable for that as well, for both the big and the small entrepreneurs develop specific things into that EHR. But we are seeing that as ACOs have come out, that there are additional tools above and beyond EHRs that are needed to support those initiatives and those activities.
Is the rule really going to be finalized in September?
Who knows? It's the government. It's an election season. Who knows? When it came out, they said after a proposed rule, commenting period was closed, which closed late June. Traditionally, it's 60 to 90 days that we see final rule come out. Is kind of the norm, which would be, today's the 30th, so it would be from pretty much now until about the 27th of September. But this is a very massive legislation that's going to be there. CMS has already been up on Capitol Hill. I'm not sure which committee, but has already gone up to Capitol Hill, and Congress has said we're hearing concerns that this is happening too fast. Our members are asking us, congressmen, to slow this down. Andy Slavitt had said, yes, I understand that. That's definitely something we're looking at. So who knows? Final rule, might come out after the election. And if so, I would anticipate that they would delay the implementation. But again, that's just my speculation there. So hopefully, and as soon as it does come out, there will be notice coming out from IRHA to all of our members. And I'll start an email list for those emails I've gotten today that I'll be able to send this out to.
Does MACRA apply to inpatient psychiatric facilities or behavioral health facilities?
Okay, MACRA applies a lot to outpatient care, some inpatient care. Behavioral health, I will be 100% honest with you, I do not know. If that person, I'm assuming you sent it directly to Alex, I don't see it in the chat. If you could please send your email, or Allie, if you already have their email, if you'll share that with me or email me, and I'll do a deep dive and look at the behavioral health piece a lot more closely. I'll be honest, I'm ashamed to say, but that is an area that I have not done as deep of a dive into over the last 2 months.
That's the last question I have. Did you have any texted directly to you, Cody?
I do not believe. I've had a few who've sent me emails, which I'll share with you, Allie, and a few who've sent requests for slides. But if you did send me a question in my chat window, please resend it, because it either got missing or I'm overlooking it throughout the chat window.
I do have one here. Be very interested. Oh, it's just sending in their email. Okay. They have a lot of questions about the behavioral health item, so I'll send that email to you.
Great. Thank you.
Now, I will give everybody fair warning, just in case there's people on the phone lines that would like to ask questions. I'm going to unmute everyone. I will say that again. I'm going to unmute everyone. So if you're having conversations in your office right now, or if there's any noise going on in the background, you'll want to remute yourself if you are not going to ask a question. We may get a lot of noise here in a second. Just bear with us for a quick second. So anyone that would like to ask a verbal question, you may do so now. I know it takes me just a second. Okay, not hearing any verbal questions, I'll go ahead and remute the lines. Let's see here, where'd Cody go?
I muted myself.
Okay, good, thanks, Cody. All right, well, I'm having a lot of requests for the slides. As long as you share your email address with me, we will be happy to send those out to everybody. For those of you that are on the phone, my email address is aorwig@indianarha.org. If you could just share your email address with me, we would be happy to get the slides out. And I also want to let everybody know, since this has been recorded, and I'll go ahead and stop the recording now, we don't need all this information.